My name is Julian. Everyone is here for the Medicaid Food Security Network quarterly convening. Thank you for being here. I am the Share Strength Director of Medicaid and Benefits Integration, and Medicaid Food Security Network is co-led by Share Strength and Health Begins. I'll just remind folks quickly that Share Strength is a national nonprofit committed to ending childhood hunger and generally improving the food security and economic mobility of people all around the country. We're doing that through helping people today through school meal programs, summer meals, school breakfast, and we're also doing it through building better systems for tomorrow. And that includes the work that this community works on, which is advancing Medicaid policy to improve food security. Just the first request we have of you, of course, is to in the chat, please introduce yourself, say who you are, what organization you're with, if you're with one, your pronouns. If you have any questions or thoughts you want to include, please feel free to put those in. And also say where you are in the world. That's also a fun one. So again, my name is Julian. I'm normally in Pittsburgh, Pennsylvania, but coming to you all today from the San Francisco Bay Area, visiting my family, and with Share Our Strength. And we have with us some great guest speakers. We have RJ Bricioni from Health Management Associates. We have Katie Ettman from Fullwell and the Coding for Food initiative. And we have several other members of the Share Strength and Health Begins team on the call who will be helping to keep things running in this gathering today. Just a few housekeeping things. We are recording this to the cloud, and if anyone couldn't make it today, we'll share it on the listserv afterwards. And please feel free to use the chat feature indeed, and that will help us keep track of who's here and be able to say hello back to you. And we'll do our best to follow any questions that come up there. Make sure that you are muted, and feel free to use the hand raise function and stuff like that too. And I feel like before we kind of delve into the full substance of this meeting, I should make sure to mention that this week and this whole month has been confusing and difficult. There's a lot going on from the federal policy perspective, to say the least. We were glad to see that the executive order about freezing federal spending on certain programs was rescinded. And we're also keeping track of the budget reconciliation process, which will be the next tool that is used to make a lot of decisions about the programs that are relevant to the folks in this room. And just to mention a couple resources that will hopefully help us make sense of all these things. First off, we have a call to action that the Share Our Strength policy team has been sharing recently, and this is something that asks Congress to protect programs including SNAP and school meals and other things that support food security. I'm also going to put in the chat a resource from the Protecting Immigrant Families Coalition, and that is something that I encourage everyone to take a look at and share with your networks and community members and friends and family, because what is going on right now is indeed distressing and harmful and disruptive to families and households, and that's a good resource that I recommend everyone take a look at. So just wanted to mention all that and to note again, there's a lot going on and we're still trying to wrap our heads around all of it, but we will do our best to share with this network what we're learning about it and how it affects our work. We'll be releasing a newsletter in February where we'll continue to talk about these topics. In terms of today's meeting and the next hour and a half that we're going to be spending together, our goal today is to increase awareness of resources in the field that relate to supporting Medicaid policy tools to address food and nutrition insecurity and increase access to SNAP, WIC, and other food as medicine programs. We will be articulating strategies and case studies that focus on Medicaid managed care flexibilities or managed care regulations. And in general, we're here to be with each other.
And I was like, oh, this is
So
real.
through fostering collaboration and engagement.
Emails while I listen. Yeah, I love you.
And sorry, quick reminder to mute yourself and
One
if
other
that
person. One of you.
Jillian, I think you might be muted. I think you might have muted
Oh,
yourself.
whoopsie. Thank you so much. I was trying to meet somebody else and then I got myself in the process. Thanks for the call out. So I was just gonna say, um, and no need to apologize. One day we'll figure out how to use Zoom. So, um, after I finish talking, we'll head over to Katie Etman with Coding for Food, and then um, I'll talk a bit about Medicaid managed care flexibilities and then hand it over to RJ. Our teammate Catherine will talk about federal collaboration for a brief moment, and then we'll have breakout rooms that last about 20 minutes. And I know some of you will need to hop off at the hour, but we always appreciate and value the time to be in slightly smaller groups. So, as a quick refresher on Medicaid Food Security Network and why we're all here today, our goal is to empower anti-hunger and food security advocates to influence state Medicaid systems so that they create strategies, requirements, accountability to support the full spectrum of food needs of children and families and close the enrollment gaps for the SNAP and WIC programs. And we're doing that through a variety of activities, including convening, collaboration, technical assistance, and creating useful tools that will hopefully support everybody's advocacy efforts. And one such thing is that we currently have an active grant opportunity um, in which we are going to fund 4 state organizations to advocate for or implement food security policy initiatives focused on SNAP and WIC within your Medicaid programs, and that is due February 14th. We did have an informational webinar earlier this month, and the recording for that is available at a link that we'll put in the chat in 2 seconds. But and you can also scan that QR code as well. Um, and one of the breakout rooms will be focused on that RFE opportunity. So if you would like to learn more about it, head to the 4th breakout room at the end of this meeting. And again, that's the QR code to the application, and I put it in the chat. February 14th is the deadline, and you're welcome to email the mfsn@strength.org email address to ask any questions you have about the grant. And we do it to that address just because there's more than one person monitoring it, and then it helps us kind of sequence how we respond to you. So now I'll hand it over to Katie Etman from Fullwell to talk about the Coding for Food initiative, which has done some great work in the past year. Over to you, Katie.
Awesome. Thank you so much, Julian. Oh, and before we move on, I spy a hand. I don't know if that's on purpose, if we need to clear that up before we go on. Allison? It could also be that Zoom is just tracking their hand. Okay,
yep,
perfect.
that was an accident.
All good. Hi, everybody. Like Julian said, my name is Katie, and I am the Deputy Director of Fullwell, a nonprofit out of the San Francisco Bay Area, and I use she, her pronouns. Here to talk about Coding for Food, which is a project that we have helped co-lead. But before I can hop into that, first I need to talk about what are codes and what are claims. You might be like, coding for food, what does this mean? I'm going to spend about the next 10 minutes talking about medical billing. So at a high level, a code is a numeric or alphanumeric representation of a healthcare diagnosis, procedure, service, or equipment. You're like, Katie, I can read. So when I want you to think about that, one of the ways you can imagine this is you're sitting in a doctor's office and the person that you're speaking to is asking you questions and taking your responses, and they're typing in notes on the side. And there is a chance that that doctor or nurse is typing in actual notes the way you and I would write notes. But in some instances, they are actually pulling and inputting codes because that's the way that we transfer information in healthcare. And when that transfer of information in a code happens for billing purposes, it moves through what's called a claim, a whole lot like an invoice, which then creates mountains and mountains of claims data. So information about how many people have diabetes, how many people are getting screened for food insecurity, for example. And then when this is related to payment, all of this moves in electronic claims or e-bills. And so it helps actually move the flow of both information and payment for different services. And so the next slide I'm going to show you here sort of takes all of this information, and we can pop over to the next one, Julian, and shows how it fits together, because there are lots of different types of medical codes. So you'll see here at the top something called LOINC. And so this is the terminology or language that we use to decide when you're doing screenings, asking someone if they are food insecure using a verified screener. And we need to be able to code that screening happened. We need to be able to code the answers to those things. You might also set up goals related to that screening. And then in some instances, you want to make sure that you can actually say what the person accessed in order to deal with the answer to that screening question. And so while medical codes sound scary and wonky, really what we're getting at here is accurately telling the story of a patient. And we want to be able to tell someone's full story. So we can pop to the next slide. And you'll see that currently we have a problem in the food as medicine space, food and healthcare, and that we don't actually have the medical codes necessary to describe the different food as medicine based interventions. And that leads to all sorts of problems. For example, and probably the most important one, you're not accurately telling a patient's story. And that means we can't treat them and that we can't get the best possible outcomes. It also means that in many instances across the country, we're creating parallel systems to cover health-related social needs. So when you get sent to a dermatologist, when you go see a specialist, and that information is moving in claims and billing and coding, we're going, oh no, when we're doing things like providing medically tailored meals or produce prescriptions, instead we're doing, say, invoicing. And so we're not truly integrating these health-related social needs and the services attached to them into the healthcare system. And if we want scalability and long-term sustainability, we need that full level of integration. And then this has also led to state-based solutions. So codes are generally national or international in scope. And instead, we have instances that right now, California, for example, and Massachusetts are using two different ways to code for the same food as medicine service. And so we're not actually going to be able to level up all of that information and claims data to do really great research. And so there are both operational and then long-term evaluation struggles of not having the appropriate codes. And so to really clarify that, we can hop to the next slide. And you will see that there is a ton of different ways that we describe similar services across the country. So what you're seeing here is that in each little box, these are different services that we sort of assume are pretty similar and being provided across different states, but they all use different language. And so I'll point out very specifically the second one down on your left. In Massachusetts, their waiver language includes nutritionally appropriate food boxes. In Michigan, they refer to something that we think is really similar as a healthy food pack. But then New Jersey, Washington, Oregon, Illinois, and DC all use the language pantry stocking. And then I love to pop to the bottom one that DC is also using the language of protein boxes. And so this shows that while we have lots of states who are working to integrate food into healthcare, in many instances, we're not using a shared language. And so not only can we not talk to one another about what we're servicing, we also can't fully communicate well to the healthcare system the value add of the services that we have and what we can be doing together. And so because of this, the Coding for Food project was born. We can hop to the next slide. So this is a community-informed initiative that I'm lucky to be leading up over at Fullwell that pulls together experts from across the country to come up with new medical codes to define the full spectrum of food as medicine interventions. And we have done that by first pulling together an advisory committee, so people from across the country with expertise across the food as medicine spectrum, and then partnering with a group called the Gravity Project, who has been working in the terminology and social determinants of health space for a long time to come together. And then we build expert work groups for each individual food as medicine service. And then we help them define that food as medicine service. So what makes a medically tailored meal a medically tailored meal? What makes a produce prescription different from a healthy food box? And then those definitions are rolled up into an application to the Centers for Medicaid and Medicare Services to apply for these new codes. And so if you pop to the next slide, you'll see that we've broken this down into 2 phases. First, happening last year and into the first month of this year, we had 4 expert work groups coming up with definitions for medically tailored meals, medically tailored groceries, produce prescriptions, and healthy groceries. And they met over the course of those months and then came up with an application which was submitted here in January to CMS, so that hopefully in the coming months and years, we will have new ways to embed these services into our healthcare system and billing system. And then if you pop to the next slide, you'll see that we have a second phase of work groups that is actually just launching as we speak. And so these are expert work groups that include folks interested in cooking education, teaching kitchens and food pharmacies, as well as cooking and kitchen supplies. And I have to note that the cooking education, teaching kitchen, food pharmacy one, it's a big name. And that is in part because what we're doing here is we are defining something like a tissue. What makes a tissue a tissue? Why is a tissue and not a washcloth or a paper towel? Why is it this and not that? But what we are not doing is telling you that you have to call a tissue a Kleenex or Puffs. We're saying that we need to come up with at a high level, what is the term for this service? What makes them alike? And so we don't yet know what the language to describe the tissue of that purple box will be, but we know that those are examples of different food as medicine services. And so we are excited to see this work move forward and come up with these additional definitions. And the next set of work here is for this first half of the project timeline, where we've gone through phase 1 and convened our work groups and we've submitted. There will now be a moment of negotiation with CMS, the Centers for Medicaid and Medicare Services, where they'll ask us questions about those first 4 definitions. And then if they are acceptable and they want to keep moving forward with this, there's an opportunity for a live conference. The next one happens in May of this year, but it's totally up to CMS whether they take our application in that May meeting or a later meeting where they are then discussed. Then if they move through that process, it goes to public comment in the Federal Register before they are officially made into new medical codes that people will be able to use and bill for. And then that sort of same process restarts again with our second phase that'll happen through July of this year. And so if you pop on over to the next slide, just because we have been able to already start both our first half work groups and we have set our second half of expert work groups, it doesn't mean that all of you can't get involved. So part of this is that every small work group who's doing an intervention specific definition comes and shares with the broader Gravity community every other week. You'll see the link here that lets you go to those meeting invites. And this is an open call. If you have people in your community or you provide one of these services and want to make sure that your program design is represented and these codes can really work on the ground, we'd really encourage you to come and join those. And if you're interested in general updates about the project, you want reminders when those public calls are going to be, please feel free to go to our landing page about coding for food on the Medically Supportive Food and Nutrition California website. And I think that was exactly my 10 minutes. And so I will pause there. I know there's a hand, but I will toss it to Julian pending if we're taking Q&A at the end or later. So thank you all so much. I know that was a lot of info in 10 minutes.
I was going to voice over. Julian, do you want me to voice over? There was a good question in the chat. I don't know if you want to just pose it. I don't know. And Sarah, do you want to come off and voice your own question, or do you want me to do it? Sarah Smith. Okay,
Sorry,
I'm gonna
people outside my office talking. Yeah, so my question really was about, have we thought of like what you all have thought about the implications of diagnosing food insecurity, as it's not an actual medical diagnosis, and how those are being considered for access to care and coverage in the future, as you know, we never know whether pre-existing conditions will continue to be protected.
Yeah, so I'm going to say that is a question that is near and dear to my heart and something that we work on in the policy realm. But when it comes to the Coding for Food project, we are very specific in that this work is related to the definition of the service. And so there is no part of our work that says you must have X, Y, or Z diagnosis, or that this service must be provided by this type of provider, or even this is what you should be paid or reimbursed for providing this service. It is really just about coming up with common definitions across the country. And then those negotiations about who's eligible, how much it's paid for, et cetera, will generally still be handled at the state and local level.
Thanks, Katie. And would love to hear other thoughts in the chat about that question, because Sarah, I think your question about unintended risks of some of these things really carries through everything we're talking about. And so really appreciate you raising that question. There's one other question in the chat that I'm going to just take one more minute, then Julian can make us go on. But do codes already exist for referrals to WIC and SNAP? If not, do you plan to address those? And then a related question about codes for case management support. And I can also pipe up here, but I'll let you start.
Yeah, of course. So in this instance, the type of code that we are looking to apply for is what we call HCPCS, which is also known as CPT Level 2, handled by the Centers for Medicaid and Medicare Services. And these are service and or programmatic codes. They describe a thing. So like a medically tailored meal, or for example, something a little bit more, it might be hospital transportation, the ambulance to the hospital. They do not cover labor. There are specific terminologies that cover labor codes. And so what we're often looking at when it comes to referral to SNAP or WIC or case management is that is the labor of someone. And so it is not related to this project. And so not something that we've worked on, but we know is an additional lever that we need to pull to fully tell a patient's story, but not currently part of our project scoping for coding for food. And I do spy another hand if we're allowed to keep going. I see.
Yeah, go ahead.
Okay. Sorry, don't dear.
Hi, I'm Julie, and I think maybe my comment was missed on that last question that you read. I was wondering about lactation related codes, the S9443 code group, and it specifically is lactation education and support for the mother and infant dyad, kind of that. I don't know if there's other codes that kind of cover two individuals with a shared function. Thank you.
I'm about to use what I think are some of the most powerful words in the English language, which is I don't know. The piece around lactation and people's access to that hasn't come up in this work. And so I apologize, I don't have a better answer, but I would be super curious to learn more about how that fits into this work.
I think there's an overlap. I think you're right that some of the lactation, I think the question is whether the reimbursement amount in that particular state actually covers the full scope of activities you're trying to jam under that code, which is related but different. That would be my 2 cents, but I'll welcome. I know there's tons of expertise on this call, so if anyone else has thoughts, pop them in the chat.
All right, thanks for this discussion. This was really interesting, and some of this stuff we'll have to take back indeed. But in the meantime, I'm gonna move us forward and prepare us for this conversation with RJ. So, quick level setting note. Many states have Medicaid managed care, which is when Medicaid is administered through contracted health insurance companies that are typically called managed care organizations, but sometimes there are state-specific terms for that, like CMO or CCO or MCP, depending on the state you're in. And for the Medicaid Food Security Network, we've kind of bucketed a variety of strategies into the following. So food security screening and referral, SNAP and WIC enrollment, infrastructure, assistance and navigation, data evaluation and continuous improvement, and investments and benefits. And to see like the full explanation of what all these things are, we have a write-up we did last year in which we describe some examples and definitions of all of these things, and I'll put that in the chat. Oops, 1 second. Here we go, putting that in the chat for everyone to read. And then we additionally, on our MFSN website, you can go to the policy dashboard we've created through this QR code, or if you type this bit.ly URL into your chat, you can see, oops, I spelled it wrong. It is MFSN, not MSFN. MFSN dash Medicaid Food Security Network. And so in that dashboard, what you'll see are some of the things that I'll show on the next couple of slides, just to kind of give a sense of here are some of the managed care tools that can be used and their prevalence in the country. Although I do have to give a couple disclaimers, which is that we created this dashboard through using publicly available documents, so it's not completely exhaustive because there may be more or less than meets the eye with these policies, which is that sometimes they're not fully documented publicly, and sometimes they are documented, but they're not actually implemented with the level of rigor and accountability that we would hope for. But nonetheless, we wanted to show some examples where, at least by our count, 16 states have a requirement for Medicaid managed care organizations to do a health risk assessment that includes food security screening. And so Iowa is a cool example because there is a requirement to use a state mandated tool, and plans are expected to screen a specific number of newly added Medicaid members by 90 days. So that's the type of like measurable goal that we like to see. Similarly, we have some examples of where states and their managed care organizations have been working on WIC and SNAP coordination. We have some examples relating to care coordination, the employment of community health workers to help people get connected to food security services, community organization partnerships. We have some examples relating to quality improvement, use of closed loop referrals, data aggregation, and as we've already heard about, coding. Coding is really important because documentation is great, and standardized coding is really important. In terms of investments and benefits, these are various ways in which managed care organizations have the flexibility in order to pay for food security services and services that help people get access to SNAP and WIC. And some of those tools include in lieu of services, and this is something that RJ will go into much more detail about. There's also medical loss ratio flexibilities, which has to do with how health insurance companies can count what they are spending towards things that improve health and healthcare quality. Community reinvestment has to do with how health insurance companies are using their excess profits to reinvest in community resources that might have to do with social drivers of health. There's value-added services and value-based payments. So value-added services tend to be kind of the classic example of that is like when your health insurance company offers you a free gym membership, but there's a lot of ways to apply that tool to help with accessing food as well. And value-based payment has to do with how health insurance companies pay clinical providers. And essentially, there are ways in which value-based payment can be applied to increase the flexibilities with which health insurance companies can pay for services that help with SDOH or HRSN or food security. And the last thing I'll say before I hand it over to RJ is that you might have noticed that just in the last few slides, I didn't spend a lot of time talking about 1115 waivers, and we do see that as a distinct pathway compared to the managed care pathway as to different ways of reaching the same end goal of let's get people better access to healthy, nutritious food. The 1115 waiver pathway also involves Medicaid flexibility, but there is a specific process by which you have to gain legislative approval, conduct a feasibility study, get all your stakeholders together and write up the whole thing, and then ask for approval from the Centers for Medicaid and Medicare Services, which is the federal agency in charge of Medicaid. So there's typically a big negotiation process that occurs between the federal government and the state government. And We think 1115 waivers are great, and they are a big lift. And some of these things that I've just named, they are also a lot of work. So I don't want to minimize anything, but they're different ways to pursue the same thing. And we think it's really important that this community understand the existence of these different tools, because the one that will work best for you depends on your state and local context and what your state lawmakers are interested in and willing to do. With that, I'll hand it over to RJ from Health Management Associates.
All right, thanks, Julian. Thanks so much. First of all, thanks to y'all for the invite and for putting this community together. I see a ton of familiar faces in the crowd and a ton of folks at places that I'm excited to see engaged in this work. You can go next slide, Julian. I'll go just brief background on myself. So I've spent a little bit over 15 years at three of the payers, three Medicaid payers, so Centene, Anthem, Aetna, and then bridge my Aetna work over to CVS Enterprise when CVS became the entity, and then moved into the consulting world about 2 years ago. Our small team inside of HMA has done a lot of work and is currently engaged in a lot of work exactly in this space. Hopefully that'll show up here. It's interesting though, Julian, I love the way we teed into this, as recently as this morning, speaking with a large food bank who is going through the exact process that you just discussed, and we'll get into that in here, of, hey, what's right for us? What's right for our state? What can we, what policy can we champion? In what way can we engage the greater health system that will actually work in our state and that will actually bring dollars in, frankly, to the food bank. So excited for that. Just amazed and excited at the community y'all put together here in relatively short time. Super impressed. Real quick about HMA, we're 900 people across the country. I think we have people in all 50 states, offices that are generally near state capitals in 20+-ish states. So many of my colleagues are former state Medicaid directors. Many of my colleagues are former payer execs like myself, several payer chief medical officers that I lean on heavily for some projects, especially when it comes to things like coding, as we've talked about. Lots of work in health systems as well. When we say health systems, that means hospitals. A lot of community-based organization work, which I straddle a little bit from my background. So my background was at Medicaid payers, and then I launched social determinants of health within Aetna and CVS, just as a brief background. And just for this community to know that I'm not, while I may have a nice shirt on today, I have sweated in parking lot, tanning out food in West Virginia, in South Florida. I've carried food from a elementary school into people's homes and realized that I needed to redesign a program because it didn't include transportation. And have done lots of those things. We've worked with Killing before. So I'm glad to be here and glad to be with you. So we'll base that there. You can go to the next slide here. Just real quick, we're going to run through some of this Julian teed up so well. We won't have to spend a ton of time on it. But we will get into the flexibility, regulations and flexibilities. We'll do a couple of fun case studies as to what the real world looks like. Talk about another angle that people don't always talk about, RFP considerations. I was talking to a prospective client about that this morning. And then some implementation considerations and hopefully leave time for Q&A. Looks like everybody can see the slides. That's good. I saw you put that question out. You can go next here. All right, so my favorite meme, my favorite way to tee this up, Colleen lived this with me for a little bit. Here's where a lot of this work starts. And it's not that it's a bad thing. It starts in a place of somebody in one of your organizations, especially if you're a food-based organization, if you're a community-based organization, and you want to go to healthcare, and somebody at the healthcare organization themselves, I was in this seat, says, I really want to work with you. Like for me at Aetna, that was, I was sort of directed towards do a national partnership, quote unquote, with Feeding America. Well, what the heck does that mean? Like, so we spent a year basically pointing at each other saying this, I don't know, what do you want to do? Right. And so the answer to that is twofold. This is the answer that I give clients. This is the answer that I try to push ourselves into when we're doing work with or on behalf of clients, is like, take something and get started, because whatever it is, you're going to iterate from it and you're going to learn from it. And this is like a startup environment. Like, if like you have to have kind of a startup mentality for this stuff still, even though we're going to get into how to make it more established. And the second piece of that, and this is where we really engage with clients, and hopefully where we provide some value, and where you'll see a little bit later here how to base this, is how do you that you need to come to the table with some kind of offer, I'll call it something structured. So just keep that in mind. Our clients, and I think we've been successful in that, and we're pushing the envelope a little bit to managed care organizations by bringing something to the table, saying like, hey, here's where our you know, give a simple example where our food box program is. Here's how much it's going to cost per person, and here's what we think you're going to get out of it, right? Instead of saying like, what could you pay us? So let's keep that in mind as we go. Julian, I just noticed we have some animation in here. I'll have you keep flipping until we get to enough pretty pictures. Sorry. You can load this one all the way up. I'll go brief because you did such a great job on this. So just remember, we say it all the time, but we probably don't say it enough. Is the top right corner there. When you've seen one Medicaid agency, you've seen one Medicaid agency. That is really true. They're all different in what their goals are, how they're going to implement things. Julian, to your point of, hey, you know, we mapped all this, but we're not even sure if it's been actually implemented. I can totally relate with that. So the point there is that fragmentation does make scale challenging, but scale within a state is definitely possible and definitely feasible. And another thing that I try to push clients into, if your goal is to serve Medicaid members and to do that via their managed care organizations, your goal should be to quickly be able to have a common offering statewide. So our more typical client lately has been State Association of Food Banks, and we're trying to coalesce them around that. Yep, we'll keep going. Yep, more pictures to animate through. Go back one, sorry. I think we covered this pretty well. In fact, you, I think, had a similar map, Julian. Just to terminology level set, you have your national players, Centene, Elevance, Molina, Aetna. Humana also, I saw Humana is here, so thank you. Sorry, we need your logo on there, especially the way y'all have been growing in Medicaid. Very impressive. I used to do these bids for a living, which we'll get into in a little bit. And then local, right? So in places like California, in places like Massachusetts, it actually leans towards local plans. In fact, LA Care in California is I think the second, or maybe the largest single Medicaid plan in the country. So somebody will probably correct me on that in here, but for argument's purposes. All right, we can animate through this. So fun slide though, and instructive for when I was sitting in the buyer seat. How do MCOs make money, and importantly, like where's your opportunity to get at some of that? So this is, we talked about, Julian talked about MLR earlier. I could spend all day on this. I will try not to, but simple calculation is at the bottom there. Not most, every state has some sort of regulatory line as to how much each managed care organization must spend on medical claims. And then they have a little bit built in. So it's probably a little hard to see in the slide itself. You will get it. I know everybody always asks that questions when you get the slides. By the way, you're welcome. We're giving away the store here. So special deal for my friends. There's lots of good stuff on these slides. So just to run down quickly, like what this looks like. The big chunks are the first one, the 20, call it 21, is ER and hospital spends. The next one is prescription drug costs. The next one is physicians, so primary care and specialists. Huge chunk here. We're separating this out so you can get the full understanding of what Medicaid actually spends on. is nursing and long-term care services. Again, varies widely. This is kind of a national average. Then kind of all the other things, dental, physical therapy, dialysis, behavioral. Now we're getting close to where you could potentially come in. So again, because of the reasons we talked about in the coding discussion earlier, you don't see anything in there that says food, that says social, at least not right now. It makes up a very small portion of it, right? But there is some room in the admin. And then what I'm working with generally when I'm a buyer for you is some small piece of the admin and some small piece of the profit, and a way, if there's a way we can put it into the medical, we'll talk about that a little bit. There are some, and we'll get into, or it's right here on how those member rates get set up. It's pretty complex. You need actuaries to do that. You have actuaries at the plan sitting across the table from actuaries at the state, kind of trading proposals on what we think the members should be rated at. It's a whole art and a science at the same time. So we can go to the next slide here. So you can, as an MCO, you can pay providers and what we'll call innovators, meaning somebody who may not be a traditional provider, but that you want to work with. You can add some animation here. So just what I want everybody to come away with here is most of the world, or a lot of the world in Medicaid, a lot of those payments that you just saw is down in that fee for service, meaning we're just paying a doctor or a nursing home or any kind of site of service for a specific service provided that they actually put the code up for. So there's opportunity in there. There's more opportunity, and Julian, you can click through. There's a couple additional pieces on here. There is more opportunity in the future, and I truly believe this, or I wouldn't be here telling you this, for arranging social and food in a value-based environment. So if you bring the little box we have down here at the bottom, if you're rewarding, the fee for service really rewards the sick care system and it's reactive to those needs. But if we can move to value-based payment, that is where there's opportunity for upstream. All right, we can go next here. Thanks. You can keep going. We're gonna have to work on the animation. Sorry, I know this is tricky. There should be something to add in here. Yep, there we go. So, man, tricky.
Hold on, do you want me at the next slide or this one?
Fill that one in if you can. There we go. Oh.
Yeah, if there was something here, it's not popping up, and I.
All right, so what's there is something probably most folks in this world are familiar with, and that is that only 20% of what affects your health happens in the doctor's office, which is something that are oh, wait a minute, are we on the wrong? I think we're, you know, oh, I see, we're back. All right, I see where we are now. Yeah, let's stay here because this is super important. So what's missing is just a map of and you should be able to get this, like when you actually get the slides, map of where waiver states are, where ILOS states are. This is an important discussion, right? Where we think changes are coming are very generally, again, because like as we've seen this week, I'm glad you acknowledged that at the beginning, Julian. It's going to be a wild ride, just to be honest, right? Like, you know, I had clients, everybody from small nonprofits to some of the largest Fortune 4, Fortune 5 companies and largest investors in the world calling on Tuesday asking what the heck was going on. And of course, nobody knew. That's was evident. So here's where we think changes are. Is right, there's this the states know best idea. right? More Medicaid decisions will be made at the state level versus a national direction from CMS. That's going to look like a lot of different things in a lot of different states. You know, I hate to deliver this message to this crowd, but you've seen it loud and clear. Unfortunately, you know, health equity is getting equated with a lot of things that it's not. And we have to live in that reality that's coming. So there's you know, I would expect to see themes of self-sufficiency. We've seen this in the Florida bid and the Florida Medicaid bid, which I'll talk about in a little bit, but there's still potential in there, right? Like the Florida Medicaid bid is all about how do you, quote, graduate out of Medicaid. Now, most of us in this room can sort of agree that like there's a very small percentage of folks that are going to be eligible even to quote graduate out of Medicaid, but there's aims in there that actually really lean on the social opportunities to stand up. So we'll take the positive out of there. We do have some new 1115s, Julian. I appreciated the way you teed these up. If I were you and if I were somebody in state policy, I would not spend much time in the next 4 years on trying to get an 1115 in. I just really don't see the door being open for that. But there's some really cool ones that are out there already that we can talk about. CalAIM, especially Healthy Opportunities in North Carolina, which were passed in the first Trump administration. So, and then we really do see the you know, on the balance of, do I see opportunity in food? Do I see opportunity in social services in states? Yes. Am I very concerned that there will be less people eligible and therefore less dollars for Medicaid? Absolutely. So that's kind of like big picture right now. We could spend all day kind of trying to pontificate on this, but as we've seen this week, the people in charge are changing it hour by hour. So, you know, stand by and hang on. That's the best I can say. And stay in close touch with great groups like this. We can go to the next slide here. Sorry about the wonkiness of the animation. This one is full, that is good. So we've talked to, I think everybody here knows this. Social determinants impact whole person health, or you wouldn't be here. I'm not going to spend any time on that. On the policy changes to address health-related social needs in Medicaid, we got 1115s in lieu of service, or including language in the RFPs, which we'll get to. All of these are separate kind of topics later on here. Medicare Advantage, there's plans adding value-added benefits that include some food interventions. There is a opportunity in, this is very small, it should be bigger, it should be better. We had conversations about this week in what's called SSBCI Medicare plans that are really great, but they're very specific to folks with chronic conditions in Medicare plans and dually eligible. We got some great evidence here. So talked about kind of the innovations. And then we have other states we're working with. So we put Florida and Virginia in here as examples. We're working with both of those states' food banks associations currently, because there's health-related social need and food interventions in those states' Medicaids, and so they need to meet each other where those have been placed in the Medicaid bids. Great evidence from Michigan recently on food as medicine. So like stuff we all know, but fun to see, 50% fewer inpatient, and then 70% on emergency department visits and transportation. So great stuff. We can go next here. All right, here's where I think you wanted to spend time. Oh, sorry, that turned out, maybe your format moved. So the left column is the pot of money for in lieu of service. Is the column going down is in lieu of service and where that pot of money is, and then some pros and cons. So just kind of going across to in lieu of service, it's I don't want to spend too much time kind of like dissecting it, but it's actually an amazing concept because it takes that evidence that we just talked about and translates it into action at a very high level. Again, like we can get into all the details, but it says like, hey, we think if we put a food as medicine intervention in, for example, there's going to be 50% less spend in the ER. So we will take that out of the budget. We will take the 50% of ER spend out of the budget, and put it towards a food as medicine intervention and go do it. All right. Like, it's not that simple. It's not that easy, but that's the high level version of it. Right. And so, obviously the pros are that's like the easiest potential policy lever. There's recent examples, very much by, the state of Michigan that has just done this and is just going live with this now. Cons are it needs to be passed by, we actually had this as a specific state entity, but it needs to be passed through your state entities, sometimes through your state legislature. I'll try to, how are we doing on time? Oh, we're rough on time. Try to make up a little time here. Quality improvement activities. I think these are important though, and probably where we want to spend time, Julian, right? The quality improvement activities, that is the quality part of the MLR where you're spending medical dollars. And the biggest pro there is that plans, when you're working with plans, a lot of the times you're going to hear, hey, can I put this in medical? Can I put this in my MLR? I'll do it all day if I can. So there's more return on that from quality and a HEDIS perspective, and it's much easier to go through the plan. It can be a little bit more complicated, and you have to agree on a model. So value-added services or benefits, I'm not going to spend a ton of time there. It's a little bit more difficult to kind of squeeze through unless your state or your plan has specifically, or the plan you're working with or specifically asking for it, and it's on essentially an annual renewal basis. There's a couple other things. One other thing here, this community reinvestment. It's interesting in that, like, there's a percentage of annual profits for not meeting MLR that at the end of each year they may have a pot of dollars available, and so it would be potentially sustainable if they expect to have MLR over the course of multiple years, or if they have a really large overage for 1 year and they can fund it for multiple years. And then 1115, I think we've talked about it a bunch. Again, Julian teed it up really well. You have to go to CMS, get it approved. You got to do a lot of stuff on your state side first, and then you got to bring it back and implement it in the state and prove that you're doing it. So we can go next slide here. All right. So this is a drawn out version. I'm probably going to leave you all with these slides and not kind of walk through them very specifically, but this expands what both Julian and I have talked about ILOS. So food benefits, generally what we've seen are up to 2 meals a day, home delivered meals, or pantry stocking. Again, that terminology that we talked about can become important. Nutrition prescriptions tailored to specific health risks or certain nutrition sensitive health conditions. So in those, you see, like, that's where you find your fruit and vegetable prescriptions, protein boxes. Again, one of those terms that we saw in the coding discussion, right? All right, we'll flip next one here. Oh yeah, so ILOS, talked about this a little bit. Really, again, I think the most fun, to use a term, and some of the best opportunity. They're alternative services that you're taking out of real spend, right? And really, the thing is that it's got to work for your state Medicaid. It's got to work for also has to work for your state politics. So there's a lot to do. There's a lot in that. And obviously it's going to be subject to kind of the appropriate monitoring and oversight and be available to evaluation. So a lot of things that we caution clients on are, like, know what you're measuring ahead of time as you get into it, and be very front loaded and ready to capture that data on day one, or you're gonna end up with a mess on your hands at the end. We go next. So QIA, quality improvement activities, which does fall in the medical expense, are health plans live in a world when I'm inside health, when I was working inside health plans, you always will have an annual set of numbers that you need to meet. Those numbers translate into some kind of quality initiative. So you may have, I'll just give an easy example. If you're in a say $800 million a year health plan, which is what I had, a typical year intervention would have been, I'll make it super simple to understand, would have been like, you need to cut out $35 million of ER spend. Wide open to how your management team, how your care management team and your medical management team wants to get to the ER spend. That's a quality improvement activity. And therefore, food, social, if the plan agrees and then plan management agrees, can go into that. And so we've seen an example of this is a for-profit company, obviously, but Farmbox RX use this model, kind of aligning their programs with the health plan's need for member engagement to get to those quality activities. So in that, they're increasing vaccinations, SDOH screenings that we talked about earlier, disease management, all of those things that are showing up in a quality dashboard that's really important to the plan for multiple reasons are eligible and available. And we're starting to see that pick up a little bit. You can go next here. I think there was a question about this earlier. So how reimbursable is referral coordination, right? Something that lots of y'all are good at, and frankly, in my view, there should be more of. So we see this, they're inside the MCO contracts, right, that they want to kind of promote social determinants, and kind of in a shift towards value-based care, they're adopting these closed loop systems, right? So the problem with these closed loop systems has been that, well, sometimes they're not fully closed loop, and a lot of the spending, a lot of the services end up falling out of that closed loop and being able to measure it really well, right? And I think there's opportunities for community-based organizations, food-based organizations to sort of help lead and help stitch that back together. We're seeing that with the 1115 implementations now in New York and in Illinois. They're taking a very measured and very really tight approach on what these referral engines, I guess, are going to look like. And then so there are some, like on the financial incentive side, on the right side here, there's some states that may incentivize some of the MCOs by incorporating some of those referral coordination into the capitation rates, and therefore that creates dollars available. A couple good examples in there that, like, I'll leave you to read. I don't want to read them all exactly, but there's where the state has contracted and said, this is important to us. We want you to be on the platform. We want you to do this, and there's dollars available. We can go to next. All right, case studies. Let's see. Julian, how am I on time here?
Feel free to take a few more minutes because we have
yeah,
I
know. I'm
at
the top here. Sorry. It felt like it was only 30 when we put it together. All right. So I'll let y'all go through, like we talked about each one of these, except we haven't talked about Oregon much, but there's some policy opportunities where that it does put community-based organizations in the driver's seat. You know, we put for now in parentheses, right? There's all of the combination of the 1115s, the ILOS in Michigan. There's opportunity there for community-based organizations. You can keep it moving. Good. There's a good readout here, a good set of information on, and these are all linked. Actually, like I said, we're giving away the store here. All linked to the, not that you can't find this on your own, but it's all in one place. All linked onto how Michigan put this together. Super, super instructive. I've been very, very impressed by this so far. And you know, their evidence review, all of that is here for you. We can go next. A little bit of so CalAIM probably the best, not probably, definitely the best from a Medicaid perspective in the country for, although I will say this, if there's anybody here from California that is a food provider, they do wish there were more dollars per instance available. The reimbursement rates are not as good as North Carolina. It does cover a wider set of individuals for food. So partially by the nature of the size of California and the number of folks in Medicaid, but important part here is it's not just food insecurity, it's individuals with very specific chronic conditions. The whole point of going upstream for food, right, is what California is covering there. We'll go next. North Carolina, again, here's the, I'll leave you to read all about it, but very comprehensive program. We worked earlier, well, actually a year ago now, early in 2024 with the North Carolina Association of Food Banks. They are really doing well on this. They're really, they are the leaders of the food side of this program, and are doing good and doing well. They're very pleased with the program, their ability to implement it, their ability to make real dollars from it, and their ability to absolutely affect the health outcomes of the folks that they're covering. So let's go real quick. I can sum this up in 1 minute because this is my favorite topic. You want to be front running Medicaid RFPs and getting in early with where your state is going to have a Medicaid RFP. It is an absolute goldmine opportunity for you to, one, get some kind of seed dollars. When I was in these roles in the managed care program, in the managed care organizations, leading business development, I had both a checkbook and some latitude to say, that's really going to work, go for it. And, you know, we're gonna highlight this in our RFP response, and we're gonna work with you in the future. Meaning another really cool trick. It's not so much a trick. I mean, most people know it by now, but most people don't pay enough attention to it, is if you get written into an RFP, the RFP response of the managed care organization becomes a legal document and it becomes their contract. So they have to do everything that they're owed in the RFP. So if they said they're going to work, so get as specific and as real as you can, and get as many dollars as you can promised in that RFP, and get something up front first to start doing it. Because what I was really looking for in that role was, can I get something started ahead of time that we can have evidence back on? Oh, thank you for the, I can't follow the chat, but I saw the big dollar signs. Thanks for the backup on that. If you get something up front, and for both sides of this deal, getting something up front, by that I mean like a year, 18 months in advance, and then having evidence back on it, like some of that evidence that we saw from Michigan, is the most crucial thing for the MCO to say, like, we did this, we are doing this, and it happened in this community or this part of the state, and we're going to keep doing it. So let's say, I know I'm way over time here, Julian. So I'll do you just this one slide here because this is some of my favorite stuff, right? And this is kind of what probably y'all wanted to get to. What do payers care about? What do they want to see when you're bringing something to them? I talked kind of about that. What's that pitch look like? So you need to create a burning platform, meaning like, hey, you know, if we're just real about it, the social side and food specifically is like, you know, this much of what an average Medicaid managed care payer thinks about on a daily basis. So realize that you're bringing that to them, but make it a burning platform. Probably talked about this a little bit. Start with targeting a certain demographic and condition. Talk about total cost of care. Has the state shown any signal that they want to do this? The experience part, very important. Don't find a way for them not to be the first somehow, some way. I know that's hard. The team expertise is important. Data, I mentioned that earlier. You've got to be thinking about that way ahead of before you hit the start button. Integration costs are the biggest thing that will throw this off. And it's not so much the cost, it's the cost in time. The interoperability, the IT, all of those things that you have to do to work with a payer. There's a million, I don't want to say there's ways around it. There's a lot of ways to make it easier. And we're working again with, actively with 3 different state food bank associations to make that easier, but it's never going to be easy. So you just have to know that ahead of time, and you've got to be able to make it as simple as possible for them, or you'll end up mired in the basement of the payer's IT world and never get up to the plate. And then of course the ROI is really what's going to be important. We talked a lot of different ways to talk ROI, whether it's MLR, whether it's quality improvement, but coming with some of that evidence on a very like population is probably the most important part. All right, there's not many, there's 3 more slides, but I'm gonna leave it there since we're way over.
Feel free to go through them, because it just means we'll shorten the breakout rooms a teensy bit.
Fair.
But it's up to you. What do you want to do, RJ?
Oh no, we can hold there. I know I went over. I would say like oh, we should probably do this one. Sorry. Yeah. So again, on the ways to frame ROI, I think this is probably an important one to think about. Total cost of care is super important, right? So you have to think about the whole person that you're going to work, that you're bringing this intervention to. What's the per member per month payment on them, and what percentage of that can you change, and can you prove that you can change? So one of the things that we do is we get very detailed into the claims of the very specific members for clients, including food bank clients. Like we're getting scientific with this and building out a cost model, and building out ROI based on evidence that works, that you can bring to a health plan. On the quality side, quality bonuses really affect the plan. Both quality bonuses and penalties. Plans have upside and downside in the quality world. You really want to be able to understand that and speak to very specific ones that you think you can affect. There are national quality metrics and standards. There's HEDIS and CQA standards, star ratings. There's some that jump out very specifically to a food intervention. There's obviously diabetes is like it's not easy, but it's the easiest one directly relatable to food that plans are typically behind on. And then member engagement, like I will do, Colleen's probably seen this evolution in me. I've done a 180 on food for engagement. There's absolutely nothing wrong with food for engagement if that's what the value prop is, right? And so when we say food for engagement, that means what can you partner with the health plan to offer food as this word is actually not legal in many states, but as an enticement, just so everybody gets the understanding of what it is. Enticements are usually in specific dollar terms are not allowed in Medicaid, or else you'd have an all-out war, which would benefit nobody in the long run. But like, what can you partner with a health plan that puts food to the member in a way that they want to engage with, that helps them understand that that is coming from their health plan, and that they have specific things to do to continue to get that food. It's not an intervention, but to get that food engagement piece. And we've seen that be successful. And that's really designing around the member, understanding the very specific needs, where they are, how they're, what their day looks like, all of those things to get that to them and land it in front of them. All right, I know I've cut a ton of time. I think we can leave it at that one.
Okay, sounds great. Well, in that case, we thank you, RJ, for this very in-depth presentation. And if you didn't already see in this chat, multiple people thanked you. And
well, it's good. Hopefully there weren't tomatoes being thrown in the chat. I couldn't see it.
No, I think in this community, tomatoes are a good thing. And
yeah,
it's even better if they're rotten, because rotten is code for
yeah.
lacto-fermented tomato. So
I can
let me hand it
pronounce it
over
like you
to
do.
Catherine
Sounds
for
much
a.
better when you pronounce it.
I'll hand it over to Catherine because we do have one other little discussion topic before we head to the breakout rooms, and that has to do with federal collaboration.
Yeah, so hi everyone. As our network gets more established, we want to start thinking about whether there's ways we should be working together to increase the success for each of us in each of our respective states. As RJ noted, every Medicaid agency and Medicaid strategy is different, but sometimes the barriers are common across states. And so we want to do a quick poll. We had been thinking through a list of opportunities for potential partnership and collaboration across the network actually before the administration change. And so have a list of specific ideas that would especially focus in on increasing SNAP access for Medicaid enrollees. So I want to do that quick poll. I also want to acknowledge that this list may not feel right anymore. And so definitely encourage you to select the other option. We'll also have a breakout room on this topic. So I'll walk through these. I know the narrative is a little bit might be a little bit cut off for you. So option A is clear federal guidance around Medicaid's responsibility to support SNAP outreach and referral. So there's a regulation for WIC that requires that Medicaid coordinate with WIC. So this would be something along the lines of similar directive that Medicaid coordinate with SNAP. B is clearer guidance around how you can braid and blend outreach funding. Sometimes I think there's a lot of confusion. So you'll have, clinic level staff who are supporting Medicaid enrollment, but they're not doing the extra work of supporting that SNAP enrollment. And vice versa. I think there's a lot of situations like that. Clear guidance around data sharing. We hear varied reports of interpretations of data sharing guidance and regulations that can impede the ability for Medicaid serving systems to effectively support SNAP outreach. And then and definitely know that some of these, we might need to be rethinking our strategy entirely. And so feel free to take the other and would love to hear you either join the federal engagement breakout room or pop them in the chat. And thank you. It looks like we have some people polling. We'd love to get a few more responses, so I'll leave it open for a few more minutes. Is there any change of the CMS, chance of aligning the USDA definition of household? That is a really good one and one we've definitely talked about in the past and continue to put in the queue. It's tricky on so many levels because the way, as you know, Medicaid thinks about people is really different, obviously, than USDA. Julie, yeah.
I just made a comment earlier that I feel like CMS needs to define the IBCLC, International Board Certified Lactation Consultant, as the provider of the clinical level lactation support, of course, in collaboration with the community level education and support by like a community health worker or a certified lactation counselor or something similar. State tested nurses aid comes to mind. Kind of getting everyone on the same page so that we can marry the care of the mother with the care of the infant. And I know that WIC also has a requirement from CMS and USDA. Not sure about that relationship, but I know USDA requires that all WIC projects work in coordination with an IBCLC so that they have that referral system in place, because otherwise all these federal dollars that have been spent by the USDA are all for naught, because we're missing that critical link to be able to provide very well evidenced lactation care and support that we know reduces infant mortality, is infant friendly, is mother friendly, and really is at the core of helping households. So thank you.
Yeah. Thank you for voicing that over. I think that's an important note, and really thinking about whole families is also something we're thinking about a lot. Also just want to flag Katie and then put a really important comment in the chat about the USD. So the new CMS guidance that came out on December 10th encourages states to use the USDA definition of the low or very low food insecurity. And if states are using low, they can use the hunger vital sign, which is the most common 2-question screener in federally qualified health centers. But if they want that very low definition, the existing assessment right now, I think, is a 6-question assessment. It's a lot longer. It's also just not as integrated into healthcare. And Katie, I can see is commenting here. Also want to give a shout out. I don't know if I think Rich is in the audience. I know that the oh yeah, you're commenting. I know that his team is working on this a little bit as well, and so might have some interesting and helpful thoughts and resources on this topic. So with that, I think, should we move to breakout rooms and we can continue the conversation there?
Yeah, let's do it. So I will open the breakout rooms, and the names of the breakout rooms will say like the topic of the room. And you can go ahead and join the room. Sometimes there's a breakout room button. Sometimes you might have to go to the 3 dots menu of your Zoom in order to find the breakout room button. But once you do that, you should have the ability to join. But if anyone is unable to find those, please send a chat to me and or to Arle or Catherine, and we can like manually put you into a room if you can't find that menu, which is sometimes troublesome if you're like joining from your phone. But yeah, let's indeed join the rooms, and we'll see you in there, and we'll appreciate the opportunity to chat. And thanks to everyone who has to drop off. We appreciate your presence thus far. Yes, the room descriptions. One was the room with RJ, and I'll hop in there in a second to sort of follow up on anything from his presentation. The second is, and I'm also typing as I say this, the number 2 will be Katie and coding for food. Number 3 is federal collaboration with Catherine. And 4 is questions about the grant opportunity. So if you want to ask any questions about the grant, that number 4 would be the place to go. Thanks, Brittany. It's good to see you. Nothing off to the breakout room, just a couple last like share outs and announcements. Okay, and I think I see people heading into the rooms, which is great. I will be joining the first breakout room, but again, feel free to join whichever room you're in, and you can also stay in the main space and just chill with whoever's here if you're not really sure where you want to end up. All right, thank you, everyone, and we'll come back in about 8 minutes. Hey everyone. Thanks for participating in the breakout rooms. We're sorry we didn't have as much time as we normally do for those, but hopefully you all got to at least ask a few questions and have good discussions. And we're just going to close the meeting now with a couple quick reminders. The first is that we are actually having an in-person summit on May 7th to 8th in Washington, D.C. So look out in your emails for information about how to participate and register for that. The details will be coming. And the other thing is just want to remind you again about the grant opportunity due February 14th. And the link is there again, or the QR code. But otherwise, please feel free to reach out to us. The mfsn@strength.org email address is a good one because, again, we have a team monitoring that. But my email is there as well if you want to reach out to me personally. And we thank you all again for being here, and we thank everyone who made it to the end of the meeting as well, because we know it's hard to dedicate an hour and a half on a Thursday. But thank you again, everyone, and thank you to RJ and Katie and Catherine and all the presenters and attendees and all of you for having great, great questions in the chat. And again, we will send you the slides and the recording, so we'll be able to share this forward.
Thank you.
Right, thank you.